Thank you so much for having me. And thank you for Verda for hosting this very important topic, as well as for allowing me to address you all today. And thank everyone for joining us on this very important discussion that we're going to have on turning the tide on obesity. What will it take? And what does that obesity moonshot look like, right? I have this diagram here of this huge problem, which is obesity. We need breakthrough technology and we need a radical solution. So that's what we're going to delve into today to kind of address, what some of those things might look like. Here are my disclosures. I'm on some advisory boards. And so if you look at this graph here, this is the state of obesity today. I probably don't have to show you all this. You're probably all well aware of it. But you can see it getting darker red, especially in the south, in the southern region there. The dark red states are greater than 35% obesity rates in those states. And this is only going up to 2019. If we look at this very important article that was published in December 19th of 2019, which is a very pivotal time, which was right before at the start of the COVID pandemic. These were 2030 predictions of adult obesity rates in our country and severe obesity, which showed that by 2030, it's estimated that 50% of the population will struggle with the disease of obesity. And it's important that one of the things I'm going to really stress today is the moonshot that we need is for everyone to accept obesity as a disease. It was declared that in 2013 by the American Medical Association, but we need the world to accept this statement so that we can advance treatment. We also know, for example, that we spend about $149 billion on obesity care costs in the United States every year. And on top of that, there's anywhere from $3 to $6 billion of lost productivity. It's estimated by 2030 that loss in productivity in the United States will equal about $580 billion annually by 2030. And those costs of obesity care will continue to increase. The pandemic also changes those things. This was a self-reported survey by the American Psychological Association that showed that people were reporting on average a weight gain there at the top of 29 pounds, 42% of people saying that they gained on average about 30 pounds during the pandemic. You can see especially our essential workers at the bottom, those of us in healthcare and the front lines, firefighters, police officers, school teachers, essential workers, 50% of those reporting a 38-pound average weight gain. Now, these are self-reports, of course, but there was also a study done in JAMA that was published that showed on average, people actually gained 1.5 pounds per month. And this was a connected scale study. This was technology showing that connected scales had a 1.5 pound weight gain a month. And if you extrapolate that over the years that have happened during the pandemic, right, that is a significant amount of weight gain that people are going to be struggling with. That may make those predictions even worse, is my point, that by 2030, we may be struggling with an even bigger epidemic of obesity than we have today. Also, the other issue that's concerning is childhood obesity. If you see these graphs here, this shows the blue severe obesity, the odds of continuing to have obesity. So if you have severe obesity as a child, you're pretty much guaranteed to have it as an adult. Obesity doesn't go away. Obesity tracks into adulthood. And there's also this huge ethnic disparity as well. You can see that Black and Hispanic people of color struggle more with obesity than their Caucasian counterparts. And that even is shown in pediatric disease here, as well as into adulthood. The other thing that's highlighted during COVID-19 is the risk of death from obesity. And so if you look at this graph at the top, where I've highlighted in red, your increased risk of obesity, if you're aged less than 60 with a BMI greater than 40, it is about 17 times the risk of death from COVID-19. If we had taken that very seriously and known today what we know, obviously we can't go back in time. But if we could help those people with a BMI greater than 40 2 years ago when the pandemic started, if we could say to them, a year and a half ago when the pandemic started, if we could have helped them get down under 35 and reduce that risk to 3, from 17 to 3, you see, or the risk under 30 is 1.89 is the risk ratio. So it's still an increased risk, but not as much, certainly, as 17 times the risk of death. We can do that. We have technology. We have tools. We have medications that could get people. We have surgeries that could get people that outcome in this past year. We could have saved potentially millions of lives from this decreased risk of COVID death. And I just say that sort of frankly because, again, we didn't know that then, but we know that now. So if we can make those changes, these radical changes, this moonshot in treatment, we can possibly prevent further deaths from pandemics. Here's our obesity treatment pyramid. And we present this as a pyramid because it layers on top of each other. And we start the pyramid at the bottom with lifestyle modification. That is the heart of everything that we should do for a better lifestyle in general. We should eat more vegetables. We should eat higher quality foods. We should move our bodies more regularly. We should reduce our stress. And we should prioritize our sleep. We should do all of these things because they're really good for us for various reasons, for our mood, for other reasons. But in effect, they produce about 2 to 5% weight loss. They don't produce a lot of weight loss when we do this, yet this is what people think is going to produce the most weight loss for them. The next category we move into is prescriptive nutritional interventions. I actually have coined this term myself. I call these things like what Virta does, right? It's a prescriptive nutritional intervention that we're prescribing intentionally to get a better result for patients. These are things like intermittent fasting. These are things like in the Look Ahead study, meal replacements. We use meal replacements in obesity treatment because they work better. When people have better control over the food that they're eating and it's more structured, people do better because the environment that we live in today is obesogenic. And we have that going on. We can also try to fix that as well. But that's a bigger global discussion also. But if we don't have control of fixing that, we as patients or individual people can try to control that. And we get better weight loss. You see, we get 5 to 10% on average, or even better in some studies. With the addition of pharmacotherapy, we can get up now into the 10 and even 20% category with some of our newer treatments. Endoscopic tools get us into that 10 to 20% category more reliably for patients. And then at surgery at the top of the pyramid is 30 to 40% weight loss treatment. And so again, this shouldn't be about the fact that I failed, that I am not good enough to control my lifestyle, and so therefore I need some other treatment. This should be like any other disease state that we have. And if the disease is severe enough and we need to lose 20%, that we may decide to employ a treatment out of the gate that's going to give us more better results. And that's what I've tried to highlight here. This slide is a little busy, but what it's intended to show is that if we start at the left-hand side with these blue lifestyle modification type of treatment programs, these are programs such as WW, Weight Watchers, intensive behavior therapy programs. And then we have our prescriptive nutritional interventions, things like the Virta program, for example. And then we have surgery. And then we have our list of pharmacotherapies that we have available to us. And what we're looking at here, if we look at the 5 to 10% weight loss categories, is specifically, let's just focus on 10% weight loss. We have 25% of people that are able to do that in intensive behavior therapy. Yet every patient I see comes in and feels like a failure because they didn't lose greater than 10% of their weight. They got down from 225 down to 200 pounds and they stopped losing. And they feel like they failed somehow. They failed themselves and they're just not working hard enough. When in fact, only 25% of people are able to do that. That's what our data shows. You can see that Virta was able to get even greater results, and these are people with diabetes even, which may even make them a more difficult disease state to treat. And they have 49% of people getting into this 10% weight loss category. So they've doubled those odds of getting into that category, so to speak, by that prescriptive nutritional intervention combined with potentially that intensive high-touch technology, right? That sort of, moonshot of treatment for obesity. You can see then when we move across the table in the pharmacotherapy range, I've also included in red when we combine treatment with pharmacotherapy with intensive behavior therapy. And you can see that we get even higher rates when we have that combination of therapy and that combination of treatment. And then we'll highlight here this 15 to 20% weight loss category. Because again, in traditional sort of lifestyle modification programs for 20% weight loss, that's only about 10% of people able to accomplish that. Yet with surgery, about 72% of people accomplish that, and that's actually at 10 years later, whereas most of our other data is only at a year. And now with our newer drug therapies like semaglutide, we're getting closer to 40% of people in that greater than 20% category. Whereas our older medication listed there is phentermine and topiramate, about 15% of people into that category. So really, these are treatment effects, right? If I'm offering you treatment A, B, C, or D, which one are you going to pick, right? And I would say you might pick one with a little better efficacy than 10%. Or you might try the 10% and you try that for a while. And if that's not working for you, again, let's employ something of higher intensity. We do this all the time with all the diseases that we treat. So our ultimate challenge is here in that despite the fact that 65% of people with obesity and 80% of healthcare professionals feel that obesity is a disease, 82% of people with obesity consider weight loss to be completely their own responsibility. They think it's a disease that they have to treat by themselves. And that's the moonshot that we really need to get out education-wise is this is not a disease that you necessarily can treat by yourself. Maybe 4% of people, 10% of people can do that. But even with intensive behavior therapy, that's challenging to do. The biggest issue that we've seen come about, I think, in the past 5 years, as far as sort of the idea of how do we make more radical changes, is the idea that ultra-processed food appears to be playing a role in the obesity epidemic. And this was a pivotal study done by Dr. Hall and his colleagues at the NIH that showed that despite the fact for calorie-matched presented meals, those that were in the ultra-processed diet, there was a 500 kcal per day more consumption of ad libitum intake in that ultra-processed food than the unprocessed diet, so to speak. And so really, if we're looking at a radical change in our society, it's to change some of the processed food consumption that we struggle with. This sort of highlights that in that this is a graph that on the left-hand side plots carbohydrate intake in our country, specifically processed carbohydrate intake in our country, with the prevalence of obesity in the bar graphs underneath. If you look at this, this is not causation by any means. This is an association. We cannot prove causation by association. But it is a very interesting association in that our obesity rates were fairly stable up until the 1980s, in which case then they take off and they start to go up and up and up as those bar graphs increase in prevalence. And this you can see is very old data. In fact, it's so old I can't remember the reference that I got it from. And so I apologize for not quoting that reference, but it definitely is a referenced article on the topic. But it's only back in the year 2000, right? If we did this even further, perhaps we would see even greater changes than on. But in these 1980s, what happened, because I know this because I lived and grew up in Iowa, and we had Farm Aid, which is where we changed over to the consumption of a higher corn-based system, right? We subsidized corn in our country, and we started feeding our animals corn because it got them to market faster. And we started to put more high fructose corn syrup and other types of additives. At the same time, the low-fat diet was the predominant diet of the time. There was a focus on eating less fat and eating less fast food because fast food had come into play earlier in that time period. And so all of these changes together, I'm not saying it's one thing or the other, but you can see where these changes has really sort of increased this over time. And that's where we need probably some sort of a radical change to affect treatment. So what works for obesity treatment? What are we talking about changing? Because as I mentioned, our environment that we have today, the human body is engineered to gain weight. It is not engineered to lose weight. It tries to hold on to weight at all costs. At the same time, we are living in an obesogenic environment that promotes us to gain more, to store more energy and to gain more weight. So it's a double whammy. So what we need to make changes is we need structure, we need accountability, we need a metabolic alternation that promotes fat loss, and we need environmental stimulus control. These are the fundamentals of how, in a basic sort of sense, and I have this acronym SAME that I like to use to sort of remember that, right? But the things that help with that, this is where we need technology, we need radical tools that help us with all of these things to help us do better and ultimately get the obesity rates going down instead of up as they are right now today. And how can we do that? We're going to talk about that next in the panel today. But there are several things societal that we can do. There's education, as I mentioned. This is your chemistry. This is not your character. This is not your fault that you're not one of the 10% of people or the 25% of people that are able to do this with certainly diet and exercise alone, right? This is not about eating less and exercising more, although that's important part of any lifestyle change. That's not the only important part when we're treating a disease. We need also for people to have coverage for these benefits. So right now we need insurance to have this as a standard benefit coverage. It's one of the only diseases that we have carved out in our treatment plans where employers have to pay extra in order to cover the medications and treatments that are in the category of obesity. And we need that to go away, frankly, and that needs to be a radical solution to say, hey, this is a disease like any other disease. We don't carve out cancer. We don't carve out diabetes treatment. And we also need some of the coverage of these programs that we know that can improve access or improve our efficacy rates of obesity treatment. As I showed that table with sort of all those numbers there, if we can get better results from better treatment, then why would we not sort of have access to that, or at least have people have better access to that than we have today? And in medicine, we have to work on either treating obesity or referring, because there are greater than 115 million people with obesity in our country right now. And there's only about 5,000 obesity medicine specialists. That's what I do for a living, is treat obesity. But there's only 5,000 of us. That would mean I'd have to treat about 25,000 patients on my own patient panel. And we don't have that kind of access right now. So we're all going to have to treat obesity more seriously in the medical space versus sort of this general recommendation of just eat less and exercise more. Very similar to mental health back in the day, where we might have said, hey, just feel better, just pull yourself up from your bootstraps and just feel better. But then medications came along, good medications came along, more effective therapies came along, and we were able to employ those and get better access for mental health and make it less stigmatizing and easier to get that treatment. And that's really what I think is the biggest moonshot today. And how we do that is the biggest challenge for us moving on. Thank you so much.